CM's really based on rigorous standards. And when people don't meet them, it's not forever. They just don't get their incentive for that week, right? They come back, and it's important to get people really, really involved in the program to understand that they can have a slip up and they come back and they can win next week and next week and next week.
Welcome to Dopamine Dialogues, the show where we meet experts working with contingency management, translating the science into what actually succeeds in clinics, communities, and day-to-day operations with patients, clients, and beneficiaries. So whether you're a provider, payer, policymaker, or just CM curious, you're in the right place. I'm your host, Larry Klemchuk. Today, I've got a fantastic guest, and it's JK Costello. JK is the Director of Behavioral Health Consulting at Stedman Group and has a tremendous amount of experience in behavioral health. Before we get started, can you please tell us just a little bit more about yourself and how you came to focus on addiction management?
Yeah. Well, thanks for having me today, Larry. Appreciate it. And I'm a physician consultant and a person in long-term recovery. So that's my trio of why I'm here and why I focus on addiction management. Because as I was in residency and I was getting into recovery, I also got my master's in public health. And I sat down with somebody who was practicing physician. I said, what could I do that would make a big difference? And he said, oh, you know opioids, and you should go into consulting in the opioid space. And so I thought, well, I don't know what that means, but I should do it. And so we do consulting with a population health lens and also lend that personal experience of addiction and recovery to our work in addiction.
Wow, fantastic. And so in public health, I mean, it's such a big area, and so you narrowed it all the way down into addiction.
Yeah, I want to get out of bed every day and love what I do, and it's something that there's a need for it. This was 2014 when I got into recovery, so opioid epidemic was just getting big on the national consciousness. It had certainly been growing for a few years since then, but where I'm from in the Midwest, it was really starting to come to fruition in those years. So I saw it as an emerging public health threat. I was just getting my degree, and I ended up in a place where I was working mostly in Medicaid and a space where addiction is more common. And so it just really made sense that I put all those things together, the personal experience, the degrees, and that love for what I do in addiction.
Fantastic. Well, I really appreciate that. Our audience is really focused on contingency management. Could you share your thoughts on how contingency management makes a difference in this area?
Yeah. And I'll start with how I got into contingency management. So I've always striven in our work to not just be reactive. A lot of consulting, you respond to RFPs, you do what people tell you to do, and that's great. We do that too. But we also want to figure out what's going to be big in 2 years, 3 years, 5 years. And about 5 years ago now, COVID was rearing its head. We had done a lot in the jail space, and I felt like we'd accomplished a lot in that space. And I thought, what's the next big public health intervention that we're going to work on around addiction? And the way I look at that is I look for things that have a lot of evidence out there, overwhelming amounts of evidence, and are not implemented to that same level. So we want to see a disparity in evidence and implementation, and contingency management really fit that bill, because the tip from SAMHSA about stimulant use disorder treatment had just come out. There was a lot more talk about stimulants because early in the pandemic, they were a very small cause of overdose, and they've risen exponentially. And so saw that coming and just thought there's something out there for stimulants, and it works for almost everything else, for nicotine, for alcohol, for opioids. And why aren't we using this? So just thought, wow, this really fits in how we operate in the policy space. And it's something we don't need to build additional evidence for. It's already out there. We know it works. We just need to figure out how to get from here to here.
Thank you very much for that. I heard you talk about you were in the corrections or the jail space. Was that in this addiction treatment as well, JK?
Yeah, absolutely. I went out to, again, looking at what works and what don't we do yet. That in 2015 was really treatment, medication-based treatment in correctional settings. That was very novel at that point, that people would get methadone or buprenorphine. And I actually got to visit Rhode Island, which had a statewide program for both medications in their correctional system. And they reduced overdoses by double digits, by more than 50% amongst
Wow.
people. Yeah, it was really an incredible amount where like, you could be a layperson and see this and know that it was a really big deal. And that's what got me going. And I thought, well, gosh, I don't have to be creative. I don't have to develop new things. They're already doing this in Rhode Island. Why can't we do it in Colorado? And similar, when that was not over, but was well on its way, I started to think about what's next. And contingency management's been done well in the past. There have been waves. And talking to people who've been in the field for a long time, they said, oh, in the 80s, contingency management was pretty big and we had funding from this and this and this. And I thought, oh my gosh, all these folks know it works and we're just not listening. Like, funding goes up and down, the pendulum swings. And obviously 10 years ago, the pendulum had swung pretty far away from contingency management.
We've had other guests that are specifically in this reentry and correction space, JK. And yes, the MOUD area of it's been successful for years and years, but we're also seeing them now apply contingency management in that space as well. But just if we're going back to your last comment, which was, yes, CM has been successful for years and years and has proven its success for decades. In your opinion, what makes CM successful in a real world setting?
Thanks. We've actually been fortunate to help implement this. COVID really kickstarted it, but we've implemented this with a few health plans, individual providers, working with the state Medicaid agency, all different levels. And I'd say the two things that make it successful in the real world are high fidelity and good recruitment. Those are the two big differences because we've had programs fail, honestly, and we've had programs succeed wildly. And those are the two biggest difference. From an external observer who's not running the programs directly, that's what I see are clinical directors who really buy in and really, really develop their policies and their protocols and do a lot of training on the front end. And I think I learned a lot of that from California, the folks at UCLA who did all the training there, that we needed to bulk up our training. And so we've done that a lot recently and seen much better results. And the other one that I'm not a marketer, I'm not a person who goes out and recruits people because I'm not at the clinic, but that marketing is really important because there's some soft, say, bans or prohibitions on marketing and saying, hey, you can get money to come here. And so this really needs to get out via individual channels. It needs to get to each individual eligible person. Say it's a stimulant use disorder program. There needs to be some mechanism to tell them all about it in a way that's balanced, but also fair to all the benefits of contingency management. So people understand how much they'll benefit from it, and to get them enrolled in the program and to get them going and make sure they keep going, because we've seen a lot of programs only enroll about half their eligible people, and a lot of those people fall off. So getting that motivational interviewing, making sure people are clear on their rewards schedule so that they stay in the program and stay on their medication, stay in their counseling, stay in their group, whatever it is that they're participating in alongside contingency management. That's super, super important so that people get all the benefits and all the rewards and complete their course of therapy. So those are the two big things: the enrollment marketing to get people enrolled, and then the fidelity to the model, because CM's really based on rigorous standards. And when people don't meet them, it's not forever. They just don't get their incentive for that week, right? They come back, and it's important to get people really, really involved in the program and understand that they can have a slip up and they come back and they can win next week and next week and next week. And it's really a benefit to keep them in the program and not get so focused on a little slip up.
No, thank you for that. JK, can I just dive in a little deeper on that recruitment? Because I agree with you, and the number of programs that we're working with across the nation, that recruitment is vital. Do you have any real kind of hands-on tips that maybe you could give some of the audience on that recruitment side?
Just because of some of the federal questions, we don't help people with external marketing. If they want to do that, that's great. But we want to make sure we're really, really, and that's not our expertise, is that external marketing. So some of the things we do from a consultancy point of view is help organizations standardize that onboarding process, help them figure out how are you going to identify all these eligible individuals.
Yep.
Often that's just an EHR poll. We figure out who are the eligible folks? What are those diagnoses? Let's figure out all those people and make sure we can put a flag in their electronic health records so that the next time they come in, or one of the next few times they come in, their case manager, care coordinator, their counselor, whoever's responsible for talking with them, they have a good relationship with them, make sure they mention the program and not just mention it, but explain it really well in a way that everyone understands and really emphasizing that there's no downside to this program. Because the only downside would be not getting the rewards, which is not a downside. It's just lack of upside. So making sure that's done exhaustively. So 100% of the people who are eligible for the program at least hear about it and fully grasp what it can do for them and the magnitude of the benefits, keeping people in the program, keeping them abstinent if that's one of their goals, keeping them in their counseling sessions. Other things we do have a patient agreement template form so that people sign this and say, I'm in the contingency management program. So there's some level of identification of I'm in counseling, but I'm also in this contingency management program. And I think that identification helps people see that this is additional above what they were doing before and maybe contributes some more to the retention. Those are a couple of the more concrete things that we do.
Thank you very much for that, JK. That's great. Going back onto Fidelity, what are the, implementing to maintain that fidelity? I know you've talked a bit about training. Are there any other items as far as like workflows go or staffing or quality control or anything else that you think maintains that fidelity? Because that was your word a few minutes ago. And I just wanted to dive in a little bit deeper.
Yeah, I think for us, that fidelity starts with, well, I'll tell you, the first thing, Fidelity started with some failed programs, and I'll just say failed. When we were early in this, we thought, gosh, contingency management's great. Let's just do it, and we'll get money out there, and we'll do whatever the program wants to do. And we did, let's see, there's the voucher program, which I think most folks use. And there's the fishbowl program where it's a little bit more of a lottery luck of the draw. And both of those have a lot of evidence for them. But what we found was that the fishbowl program is a little bit looser, and we mathematically could see that there was some laxity in how it was being worked. And I'm not saying that this can't work. I mean, tons of programs that have worked at. For us, it was apparent that a lot of people were magically getting the largest incentive amount allowable, many more than one would expect by chance. And so it was clear that there was some fudging of the facts going on by staff.
Fidelity issues.
And that was the cool thing is that we could just see that from the back end that, hey, if 15% of the time somebody's getting an outcome that should happen 1% of the time, there's something wrong here. So we started engineer backwards of what is a program that we can externally help implement and make sure that it's both effective and not anywhere near fraud, waste, and abuse. We want to stay as far away from those as we can. And so really that started with the program development. Really, it did not start with, let's implement this program that they've designed. It's, we know what works now. And so we're going to help folks implement that. And so I'll just be honest, for us, that's usually been voucher programs where there's a fixed, not necessarily fixed, but predictable set of incentives. They can escalate, they can reset, but it's predictable. And we can say, this is what's going to happen. If you come in and you test absent for stimulants 3 weeks in a row, you will get here. And if you have one test where you slip up or you miss it, you're going to go back down here. And it's better for both staff and the patients to hear that definite part of it. And other things, I mean, just basics was, what's your drug of choice? What is eligibility criteria, right? Is it alcohol? And so that, again, required a look back at where's the funding coming from? So even the Fidelity really traced back to eligibility, funding, program design, implementation, training. All those things really need to be determined up front to have a good program. Can you have 2 use disorders? What if you have opioid and stimulant use disorders? What if you're on medication? All of those things happen. They happen pretty commonly because of the frequency of co-occurring disorders. What about if you're on mental health medications for ADHD? All of those could mess with like stimulant use disorder results. And so we realized that Fidelity started way, way, way before with, looking at what state or federal agency is going to fund this or opioid settlement. what's most common there? Stimulants is the issue. Let's try to focus on stimulants. If you're OTP, a methadone clinic, they're treating people like this, right? And so there we might be looking at co-occurring disorders or adherence to treatment rather than abstinence from a substance. And so, sorry, I don't have a great answer for Fidelity just because there was so much that went into Fidelity monitoring up front that like Fidelity monitoring kind of became more obvious once the program was designed and trained and things like that. Some of the things we do for Fidelity monitoring is we have them use usually a platform. If not, some of the folks couldn't afford a platform, a spreadsheet that kind of tries to mimic a platform. So they're recording every outcome, definitely every time. They're given an incentive so that if somebody audits this, it's not even a lot of work. They can just show them their spreadsheet or platform, say, look, it's good, because we don't want there to be a lot of work on the back end. And Fidelity monitoring also helped ease evaluation. For us, often we're the external evaluators, and it's great to be able to say, hey, can you download your spreadsheet? Or even we get access to it, so we can just download what happened over the last couple of weeks and say, here's where you are, create a dashboard. So Fidelity, again, it comes from all the stuff before, and it makes all the stuff afterwards a lot easier. We know what's going on in the program. We know it's effective.
I think that was a great and very comprehensive view on Fidelity. So thank you very much, JK. At the end there, you were talking a little bit about outcomes and measurements and reporting and ROI considerations. Could you touch on that a little bit from a perspective of payers and policymakers?
Yeah. So this is a loaded answer. I mean, we always go back now, even though there are a lot of different entities funding CM, which is great. Like, we want a diversity of funding options because, as we've seen in the last year, things get shaken up, things fall apart, things change, budgets change at the state level. So we want some redundancy in funding, knowing that, hey, SAMHSA funds this, Medicaid plans fund this, opioid settlement plans fund this, because one of those could go away, and because they each have different interests. Like, the state opioid response grant is just opioids and stimulants. Opioid settlement is mostly opioids and stimulants, but other state money might be alcohol. It might be nicotine for pregnant women or for kids. Might be cannabis for adolescents. So how that relates to outcomes is because the funding source sometimes specifies the outcomes of interest. And so we really try to get people to go back to the SAMHSA, CMS OIG guidance that says, when you have a stimulant-focused program, you can look at abstinence from stimulants and attendance. If you have an opioid-focused program, we want you to look at adherence to medications, because a lot of people have great but different ideas about what the outcomes might be. And we see that as kind of the guiding document. And so when we work with a state Medicaid agency, we say, hey, let's try to get your outcomes of interest to align with their outcomes of interest. So we don't have people with a program for alcohol that's based on this and this length and this amount of funding. We say, like, let's try to decide on an incentive level it's going to work for all your programs. Let's focus on outcomes of interest that work for all your programs. And so that really has helped us work on outcomes of interest. And we don't have to reinvent the wheel here. There's some guiding documents. We see that SOR, State Opioid Response Focused document, as it was the first, and it's been consistent for a couple of years now. So we try to set things at $750, right? $750 is the incentive limit that they recommend. And so the outcomes of interest are based off that. And we also want folks to, when they have those programs and say they apply for a grant like opioid settlement, instead of being reactive to what the opioid settlement grant wants, they can just say, here's what we measure. We're going to measure abstinence from stimulants and how often people attend their groups. And that's what you're going to get, so that they're not having to track different outcomes for different programs. And they can have this program be a little bit more compact, not a lot of administrative staff, so that when some of those funding options go away, they can still maintain their program.
Very good. Very good. I do hear consistently, from experts in the field like yourself, JK, is, having that focus is so important. Exactly what are you trying to achieve here? And getting that across in your internal clinical training, but also ensuring that your patient or customer completely knows what's going on here and you're not diluting the whole process. So thank you for that. Others, CM's been around for a long time, and earlier today, JK, you were talking about It's kind of gone into and out of funding or fashion and everything. You know, after 30 years, are there still any misconceptions about CM out there?
I I think podcasts like this, trainings, documents from the federal government have helped level set a lot better over the last 3 or 4 years. Groups like the Motivational Incentives Policy Group that have tried to get out information about this to policymakers, to providers. There's a lot more consistent ideas about contingency management. There's a lot more knowledge of contingency management. I mean, I'm a great example. 6 years ago, I used to read about this, and every time I saw the words, I had to look it up because I thought, I've heard of that, but I don't know what it does. And so the misconceptions that I see remaining, well, let's talk about what's gone away. I think the $75 thing, I don't hear that anymore. So that's a big win. A lot of people thought there is this blanket ban on giving any incentives to any patients over $75. That was never true. It was true under some specific grants, but that was not necessarily true for Medicaid funded programs, grant funded programs. And I have not heard anybody say that for quite a while. I'd say the misinformation or misconceptions I get now would be the laxity in outcomes. We still have some folks, usually who they hear about this in a webinar and they think, I'm going to go do this. And they go create a program and they do something that's really helpful for their organization, but it is not in line with evidence. And that, what I mean is the behavior, that target behavior. We had one organization that was having people clean up their parking lot. That was pretty obvious, like not of clinical interest. Great for you. You get free parking lot cleanup and you take somebody else's money and pay them, but not necessarily keeping that person on track. In a little bit more reasonable areas, we've had people, for instance, incentivize going to 12-step groups. That's a great thought because 12-step groups do work. And they're great because people can go to their clinical treatment and they can drug test. And that adds something outside the clinical sphere. The problem with it is it's not immediate and it's not verifiable because as somebody who's had his court card signed at 12-step groups, there is a burgeoning market in signing each other's court cards and verifying that you've been in a 12-step group. So even though we'd like to assume the best of everyone, they're all telling the truth, that's pretty easy for people to circumvent. This has to be verifiable and it's got to be immediate. And so I think it might not be a misconception, but something that people come into the program thinking about, oh, we'll do a send-off drug test and then we'll give them their incentive in 10 days. Or we'll incentivize this behavior that we know is good, but we can't verify. Those are two of the things that we frequently see in programs that have developed on their own that we try to come in and work with them on to get it more in line with generally accepted evidence-based practices.
And very good real life case studies there are examples, JK. And I do also love, and I have to compliment you. You also talk a little bit about learn from failures. And I think that's important for everybody to understand that. Well, I've only got two more questions. The first one though was, you talked a little bit earlier, but also expanding out to kind of things like cannabis, nicotine, alcohol. Where do you see CM headed in the future?
I think alcohol is probably my number one because it's such in a public health sense. Public health, alcohol is by far the largest cause of deaths, disability, chronic medical conditions related to substance use, and that is not to undercut opioids because they've been in the headlines. They kill a lot of people and a lot more people than they used to. But I actually just wrote an op-ed yesterday about this, that we should treat chronic problems of the same or greater severity with the same immediacy that we treat more acute problems like opioid overdose deaths. And now it's time for us to turn to alcohol because opioid problem is not solved. Still lots of people dying, lots of people being treated for substance use, for opioid use disorder. Alcohol's always been in the background at a very high level. Where in Colorado, I think we've got more people dying every year from alcohol, even through the pandemic, through the spikes in opioid overdose. Alcohol was number one the whole time. And there are some states where that it's not even close. Alcohol kills several times more people than opioids. And I don't mean to just focus on the deaths, right? There's a lot of disability that comes with chronic alcohol use. And it's actually fairly easy to set up a CM program around alcohol. Really easy because alcohol has a short half-life. And so it is easily testable in a short-term acute setting. And to demonstrate this, the second place I went to treatment, every time someone returned to campus, you breathalyzed. Every time. If you left a dozen times in a day to go appointments and you came back, every time you breathalyzed. And every time you got an immediate look back at the last few hours of your alcohol use. And it was really easy to then take action with people and say, oh, well, you're going to be on restrictions for a couple of days. So that's a principle of contingency management, is that immediacy. And so we've seen programs where people have a at-home breathalyzer that's linked to a cellular transmitter, and it passes on the results right away. And it can go off at 11 p.m., it can go off at 7 a.m., it can go off at noon, it can be randomized. And the coolest thing that I saw from that was there was a person being treated for alcohol use disorder who had a traumatic brain injury. And he had a lot of trouble with memory, he drank a lot, and they set it to go off late every day because they knew he drank throughout the day. And he had, like I said, some limited, he had effects of the brain injury going on. So memory wasn't very good. But when focused on one goal, don't drink until after you breathalyze, he could do it. And so in the evening at 8 or 9, it'd go off and he'd get his $10 or $20 and then he'd drink after that, right? But what a big win for this guy who was drinking from when he woke up until when he went to bed to cut out 80% of that time. I mean, huge win for $10 or $20 a day.
Right. Right. No, I really appreciate that, and I think you're spot on. I mean, alcohol is so much bigger than any of these other areas, so it's an important area to address. And I think that you're absolutely right. Again, that contingency management can and is helping in that space too. It's that immediacy that is so important, and you highlighted that, JK. So that is great. My final question, JK, is actually, is there a question I should have asked you that you'd like to answer?
Oh, geez. Well, if it was you saying it, you'd say, what's your biggest win in the contingency management space, JK?
Okay, JK, what's your biggest win in the contingency management space? Share with us.
Great question, Larry. That was the best question I've ever heard. We actually, I mentioned how we try to be proactive about our consulting. And one of the barriers, absolutely, when we talked with people around Colorado in 22, I think, was the lack of funding. And at that point, there was a severe lack of funding. Federal grants couldn't be used because they had that low $75 limit. We didn't have any state funding for it. Medicaid plans weren't really thinking about this. And so there just wasn't funding. And we didn't want to start a program at that $75 level because we didn't think it was effective enough. And so I got to advocate for contingency management through a state bill. We had a big omnibus treatment bill for all types of substance use disorders. And I said, hey, put in a grant. It doesn't cost that much. And it got cut down a little bit, but it was $750K per year starting in 24, I believe. And that's enough to fund thousands of people in contingency management in Colorado every year. And so we got that grant working and moved people off. They had an SOR program, but it was that low limit. So we could move people up to 750. We got it scaled in some big providers. So the administrative burden was relatively lower. And now I don't know how many people, but I think it's nearing 1,000 have been treated in Colorado through a very effective contingency management program funded by the state and uniformly rolled out across several providers. So that was really some of the dreams and skills coming to fruition here in Colorado. And we want to pursue that avenue, but also having uniformity over different types of funders, different substances of interest, so that everybody with substance use disorder can benefit from this highly effective program.
Well, congratulations. I love hearing these wins, and that certainly is a success story if you're saving 1,000 lives out there and everything else that goes along with that besides the lives. So thank you very much. JK, I have certainly learned a lot in this discussion that we've had today. I really appreciate your feedback, and I also admire your passion and your ambition for this space. So really, thank you very much.
Awesome. Good to be here, Larry.